looking at what makes ankle arthritis unique, who gets it, and why. We'll look at treatment options, starting, of course, with non-operative treatment, and then looking at ankle fusion and ankle replacement, comparing and contrasting the two, looking at where there are pros and cons and where they have overlaps. So let's start off with that question of who gets ankle arthritis and why, and what makes this population unique compared to arthritis in other joints. So as you have seen at this point, arthritis is a process and is not a thing that can be removed. So ultimately, it results in the loss of cartilage, the smooth gliding surface in a joint, exposure of the bone underneath, which contains pain fibers, which produces pain. Cartilage does not have pain fibers, swelling, inflammation, and ultimately the X-ray findings that you probably become familiar with in other joints, which include loss of joint space. If we look over here on the right at the ankle X-ray and AP of the ankle, we see that there's no dark line between the tibia and the talus where the cartilage would live. This ankle has fallen into some varus alignment, so there's increased loss in the medial aspect of the joint. Osteophyte formation as the joint reacts and tries to spread out the force it is seeing. We can see that here in the medial gutter by the medial malleolus. Subchondral sclerosis, which is the bone becoming more dense as it deals with increased force. That appears as a whitening or an increased density on X-ray, which you can see both in the distal tibia and the talus. Subchondral cyst, which you can see starting to form in the medial malleolus, and the malalignment I mentioned earlier, falling into varus or valgus typically. Again, as we move forward, we're going to be talking about the ankle joint or the tibio-talar joint, which is separate from the triple joint complex, the next adjacent group of joints, the subtalar joint, the talonavicular joint, and the calcaneocuboid joint. So one of the things that makes ankle arthritis stand out when compared to other joints is that the majority of ankle arthritis is post-traumatic and not degenerative. So as opposed to occurring throughout the course of time, oftentimes spurred on by genetics, ankle arthritis for a large part is due to either recent or distant trauma or malalignment. So there are some other groups of patients that also develop ankle arthritis more consistently. Those include patients with inflammatory arthropathy, the inflammatory condition that attacks the lining of a joint and also leads to degradation of cartilage. Congenitive or post-traumatic malalignment, which we mentioned previously, and hemophilia, which results in frequent bleeds intra-articularly in the deposition of hemosiderin and degeneration of the joint. There are some unique challenges to these patients that come along to some degree due to the mechanism of the process. So one is that they tend to be younger. In general, over a decade younger than patients who undergo total knee or total hip arthroplasty. And that has consequences for the longevity of implants and the general stress and strain that occurs on those implants. As you can imagine, a young laborer will put more force through their joint than will an older person who is looking to ambulate around their house or their local community. More males than females develop ankle arthritis. As we talked about, the vast majority of this tends to be post-traumatic, and it's a relatively rare entity. So when compared to knee arthritis, it's about a tenth of the frequency of knee arthritis. And so not as many folks treat it, or that treatment tends to be spread out. And if we compare treatment to other joints that we see frequently that develop degenerative arthritis, namely hip and knee arthritis, it is less prominent, as we discussed. The arthroplasty options tend to be less durable, so it can be difficult to compare ankle replacement to hip and knee replacement or even shoulder replacement. It can be more complex just in terms of deformity and implants, and the recovery is harder. The majority of hip and knee replacements will be able to walk post-op day 0, where there's oftentimes a longer period of non-weight bearing after ankle fusion or ankle replacement. So all these things make the patient population, the treatment, somewhat different than some of the other arthritis patients you may have seen in clinic or the wards. So we touched upon the fact that trauma can lead to ankle arthritis. This is an old study that looked at patients with bad ankle fractures. So these are all fractured dislocations, and looked at how they did over the long term. And potentially, surprisingly, the severity of the ankle fracture corresponded with the outcome, as did the initial treatment or ultimate treatment, whether that was operative or non-operative, the quality of the reduction, so how well the articular surface, the tibia, the fibula were put back into alignment, led to variations in how much arthritis people developed. And the severity of that arthritis corresponding with the severity of the fracture. So a posterior malleolus fracture, typically indicative of a more severe injury, led to poor outcomes down the line. So just as when we're treating ankle fractures in the acute phase, we are trying to avoid the complications that come thereafter. And in this case, it namely is arthritic changes. One of the reasons for that is that there is a large amount of force, essentially all of your body weight above the distal tibia, going through a relatively small area. So up to 3 times the force that's seen in the hip or knee, and only a third of the articular surface that it's going through. This is a classic study that looks at in this relatively small joint with high forces going through it, does a small change in alignment lead to a large difference in pressure? And the answer, as determined by the study, is yes. The pictures on the lower level demonstrate pictures of a talus with Fujifilm, which essentially demonstrates contact between the tibia and the talus, and small incremental changes in the alignment of the tibial plafon as it sits on the talus. And you can see if you go from the left, where there's a relatively broad swatch of black contact, to the right, where it's a very narrow, concentrated area, that indicates very small changes in alignment, 1 millimeter shifts, leading to large differences in pressure. So at the end of the day, the quality of alignment of a broken ankle has consequences for the amount of force that will go through that ankle and the potential to develop arthritis, as concentrated areas of force can lead to degeneration in the cartilage. We also know that the mere fact of having a fracture and the injury to cartilage that occurs thereafter or during the process, regardless of the quality of the fracture reduction, can lead to increased rates of arthritis. So one other question one might ask is, well, how bad is ankle arthritis? Is it as debilitating as other types of arthritis? This is a study that looked at asking people who were awaiting either treatment for ankle arthritis or treatment for hip arthritis, how bad their symptoms were, looking at predominantly the SF-36, which is a patient-reported outcome looking at overall health measures. The total score is there on the left, and the PCS represents the physical component of that score, the MCS, the mental component of that score. What you can see is that ankle arthritis is on par, as debilitating as hip arthritis. So we know that we've got a relatively young group of patients with a relatively unique type of arthritis that is affecting a relatively unique joint. What are the options to help them when they come into your office looking for treatment? So non-operative measures are usually where one starts. One, because they can be quite effective, and two, because they avoid the risks and potential complications of any type of surgery. Those include things like bracing. On the far left, you see an example of an Arizona brace, which is a custom-made brace that's made out of leather and has a nylon shank and is designed to decrease motion through the tibio-talar joint, decreased motion leading to less pain from those abraded surfaces rubbing against each other. Similarly, the shoe in the middle is a rocker bottom shoe, which is designed to defray some of the dorsiflexion and plantar flexion that might go through the tibio-talar joint by allowing the rolling motion of the heel to take up that motion. And then on the right, an injection, various forms of anti-inflammatories or over-the-counter pain medications can be helpful, topical, oral, injectable in some cases. And of course, activity modification. One of the most important things to understand about any patient is how they're affected by their disease, what their goals are, and whether those goals are accomplishable with different treatment methods. So ankle fusion and ankle arthroplasty are not the only two surgical options out there. There are some less frequently used options. If we move from left to right, looking at the pictures on the screen, distraction arthroplasty is a technique that places a frame traversing the ankle joint and pulls traction through it to help with pain and the effects of arthritis after removal of the frame. In the middle is a supramalleolar osteotomy, so cutting and realigning of the tibia and the fibula to help offload relatively worn areas of the joint or help correct malalignment above the joint. And on the right is a demonstration of a predominantly anterior ankle arthritis, which has led to anterior osteophytes, which have been debrided predominantly to treat decreases in ankle dorsiflexion and symptoms that are localizing to the anterior ankle joint. So while all those are out there, ankle fusion and ankle replacement remain the two major options. And if we think about them philosophically, the idea of an ankle fusion is to eliminate the joint, and the idea of an ankle replacement is to resurface the joint. So in the case of fusion, essentially you're removing cartilage, any remaining cartilage from between the tibia and the talus, and creating a physiologic fracture that the body will then heal, turning the two bones, the tibia and the talus, into one bone and eliminating movement through that joint and pain because of that movement. A replacement takes the worn out surfaces and replaces them with a new bearing that eliminates that discomfort. Some combination of metal and plastic, we'll see some variations on that theme moving forward. So if we look at the two treatment options side by side, it's important to realize that the vast majority of studies show that there is equivalent pain relief in the long term after these two procedures, but there are relative trade-offs. If we look at the left side of the screen and look at fusion or arthrodesis, the relative pros include durability of the fusion. Once the tibia and the talus have fused and created one bone, the hardware is essentially extraneous, and it is as strong as any other healed bone. I tell my patients that they can enter a wall kicking competition if they want. After an ankle fusion, they don't have to worry about it breaking down. Overall, it has a lower complication rate as well. The cons are that it does result in a stiff joint afterwards, so you lose the motion that would come through that tibio-talar joint of dorsiflexion and plantar flexion. It is permanent. While there are some exceptions to this, there are opportunities to rarely take down an ankle fusion and convert it to a replacement. In general, it is something that you cannot be reversed. And adjacent arthritis. So when you eliminate motion through a major weight-bearing joint, that motion is transferred to other joints. If we look at replacements on the other side, some of the pros include better range of motion from the resurfacing of those joints with plastic and metal, better gait patterns as a result of that. Cons, a higher overall complication rate from replacement than arthrodesis. The salvage options are relatively limited as well. It doesn't mean there are no salvage options, but in general, failed hip and knee arthroplasties, for comparison, have more treatment options if they fail and better implants to treat them. So it is not a simple transition to go from a failed ankle replacement to an ankle fusion. So let's talk about these in succession. We'll start off talking about ankle fusion or arthrodesis. So there are different techniques, but the goal is the same. You're creating this fracture at the joint and trying to convince the two bones to heal together into one. That includes scraping away the remaining cartilage, creating holes in the subchondral cortical bone so there's communication between the marrow cavity and the cancellous bone between the tibia and the talus, and then keeping things from moving. So squeezing things together until those two bones have joined into one. On the left here, you see one way to prepare the joint, with this, which is arthroscopically. The silver represents a burr or a debrider that is in the joint. The tan represents the subchondral cortical bone of the talus, and you can see some small patches of cartilage. This can be done open and frequently is done open as well through an anterior or a lateral approach and even a posterior approach. And then hardware fixation, there are numerous options you see demonstrated on the right, plates and screws to eliminate motion through the joint as it fuses together. Screws themselves can be used or used independently of the plate. As you see, there's an independent lag screw in the construct used on the right. Where do you place a fused ankle? Well, the short answer is where it would normally want to sit and where the other side sits, assuming that it doesn't have malalignment or degeneration. So that means neutral dorsiflexion, so about 90 degrees of dorsiflexion, physiologic hindfoot valgus, so the slight amount of valgus orientation that is natural to the hind foot, equivalent external rotation to the contralateral side, and then oftentimes posterior translation of the talus on the tibia as it tends to drift anteriorly with the degenerative process. How well do these patients do in the long term? This is a study out of Iowa that looked at patients over decades and how they did with ankle fusion, and looked at both radiographic and patient-reported outcomes thereafter. And the short answer is that while there are benefits to ankle fusion, as we saw before, the pain relief can be quite good. There are still some issues. So when we take away the motion from that joint, it means that that adjacent joints can develop arthritis as well. Assuming people are going to be walking in a similar manner, that motion gets translated predominantly through the triple joint complex and more distal joints in the foot. As you can see here in the X-ray on the right, there is bone spurring and loss of joint space at the talonavicular joint especially, but also the subtalar joint. Patients in the study also had decreased activity, increased pain, and increased disability of their fused ankle side when compared to the contralateral side. Their gait can be close to normal, so I tell patients that if they have a successful ankle fusion in the position we want it to be in, and they wear rocker bottom shoes or other proper footwear, that people may not know they've had anything done when they walk down the street. When walking barefoot, though, and without supported devices, there are some differences in gait, including use of more energy, less efficient gait pattern, shortened stance phase, and a relatively slower gait. So while people do well, they don't do perfectly. And much like any surgery to treat arthritis, it's rare that an arthritis surgery, fusion, or replacement can give someone the ankle, the hip, or the knee that they had decades ago. The goal is improvement upon where they are now and return to the activities that are most important to them. Other complications, a relatively common complication that occurs somewhere between 5 and 10% of the time is non-union of the joint, oftentimes necessitating revision arthrodesis. And if we roll things back and think about, well, we've talked about some complications, some challenges, what philosophically might be improved upon with an ankle fusion. I think that really stems from the concept that you're taking a joint that, when healthy, can have a large degree of motion. Should be noted, an arthritic ankle And someone who's considering fusion or replacement rarely has that full 70 degrees of motion. But if you take a joint that normally has motion, you lock it up, there can be altered mechanics and adjacent joint arthritis. And so the question becomes, can more normal ankle function be preserved? And that's where interest in ankle arthroplasty began. So we're going to talk about replacement or arthroplasty in the second half of things here. So the concept is the same as a knee replacement or hip replacement or shoulder replacement, which is that the affected joint is being resurfaced with metal and plastic to decrease pain and maintain as much motion as possible. There are various ways to do it, but the concept is the same, and they're all variations on a theme of having a metal resurfacing of the tibia, the talus, with plastic in between. There are various ways to anchor that, some relatively bone preserving, some with more stability from the implant. The majority of these implants are put in through an anterior approach to the ankle, although at least one down in the lower right corner is put in through a lateral approach to the ankle. And there's been an evolution of these implants. While many of these are modern implants, they're implants that have been around for decades and have continued to evolve and change. As we talked about, there are studies that show that people can walk more normally following an ankle replacement, that show that gait after a total ankle arthroplasty is similar to normal patients. Should be noted this isn't a universal finding. And again, as we mentioned, an ankle replacement is extremely unlikely to give someone quote unquote normal range of motion of their ankle, but the goal is improved range of motion. As we mentioned, in terms of the trade-off, the complication rate is the major thing that is higher in the total ankle population as opposed to the ankle fusion population. Those can be relatively small things, things that don't require a second operation. They can be things that require a relatively smaller operation, meaning that the metal components of the ankle replacement are retained, or they can be things that are considered a major revision, which involve removal or replacement of the metal components. Um, if we're being honest about the majority of implants being placed in the United States now, we don't know what's going to happen 15, 20 years down the line because they simply haven't been in for that long in a large enough population of people to know what's going to happen to them. And as we mentioned in the study here that looks at some of the intermediate term results, same pain and functional outcomes as fusion patients. It does beg the question, though, well, what happens if these wear out or fail or need to be replaced? Um, Salvage is relatively harder than it is in other joints where we typically do arthroplasty, like hip or knee replacement. If we look at the patient in the middle here, an AP and a lateral as opposed to total ankle arthroplasty, we can see a couple of things. One, we can see osteolysis or resorption of bone surrounding the tibial component in the distal tibial metaphysis and the distal fibula. We see that osteolysis underlying the talar component as well. We see some malalignment, some drift into varus, all indicating signs of failure. There are two main options for aseptic failure of total ankle arthroplasty. If we go down the road to the left, it can be converted to fusion. Typically, that fusion involves fusion of the subtalar joint as well, as is the case in the images shown on the left. This is a sagittal and coronal shot of a CT scan showing a talocalcaneal, tibio-talocalcaneal nail. And in the middle, this round substance is an allograft femoral head, so donated cadaveric femoral head that's taking up the large space that's left when you remove the metal and plastic from the ankle replacement. And clearly, this bone needs to be over time replaced with the patient's own native bone for a successful traversing fusion across that area. In the absence of filling this void with bone, you are shortening the limb quite significantly. So Fusion is an option after failed arthroplasty, as is revision arthroplasty, shown on the right. Much like similar arthroplasty constructs in the hip and the knee, bone loss instability is taken up with increased mechanical stability from the metal and the plastic, which typically restricts or uses constraint, I should say, to add stability that normal biology or physiologic structures would in the primary setting. So while revision implants have improved over time, they're still relatively few and relatively rare. So contraindications are the people out there where arthroplasty just simply isn't a safe or preferred option. And there are, I break those down into three different categories here: those who can't heal, those who can't feel, and those who can't hold. So in the can't heal category, anybody with peripheral vascular disease and significant risk of non-healing or wound breakdown is at risk for an arthroplasty. Um, like other areas of the body, if you develop an infection that sets up glycocalyx on hardware, it can be very difficult to treat infection without removal of that hardware. Um, and that can be a major complicating factor. Inadequate soft tissue, whether that is acute or it is chronic, including ulceration or soft tissue transfer that may have occurred. Infection, we mentioned before, but an underlying infection that is at risk of redeveloping or infecting an arthroplasty is to be avoided. And prior incisions can dictate where future incisions can be made and may negate options. So can't feel, those with neuropathy or neurologic disorder without normal or close to normal motor function of their limb are poor candidates due to the abnormal loading forces that would go across an arthroplasty. Charcot arthropathy or degenerative arthritis due to decreased sensation is also a contradiction. Can't hold, we're looking at inadequate bone stock, so bone loss either from trauma or previous surgeries. Talar avascular necrosis, as shown in the upper left picture, with increased radiodensity of the talar bone stock. This means that there is less likelihood of incorporation of the implant into the talus and higher risk of failure. And then coronal plane deformity, so insufficiency of restraining structures that can't be made up for with other realignment procedures, which are oftentimes done in conjunction with arthroplasty, and where fusion is a much more reliable option. So in general, if we back up and look at an overview, we've talked about the fact that ankle arthritis patients have some unique challenges. They're relatively young. There's a male predominance. A large percentage of these patients are post-traumatic. It is a relatively rare form of arthritis. And there are some treatment challenges when we compare these patients to similar patients in the hip and knee world. If we look at the relative pros and cons of fusion versus replacement, they have equivalent pain relief, but fusion patients have a more durable or permanent treatment option that comes with stiffness and adjacent arthritis, whereas arthroplasty patients have better range of motion and gait at the trade-off of a higher complication rate.